Welcome back to Sensible 2020. I'm your host, Seth Adler. Very much appreciate you being a part of this. We've had excellent sessions throughout the entire event. And so here is the very next one. It is the opioid crisis, the West African opioid crisis. Your host is Róisín. Róisín?
Thank you, everyone, and welcome to our panel today. We're going to delve into one of the most pressing topics of drugs and drug policy in West Africa, but also across the continent. Today we're going to have Maria-Goretti Ane Loglo and Axel Klein. They're going to introduce us to the topic based on some research they've done on opioid and tramadol use in West Africa. They're going to give us a little bit of an idea of the political landscape, policy needs, and idea about the research that's going on currently. Maria-Goretti is the African Regional Consultant for the International Drug Policy Consortium and has been a great friend of SSDP for some time now. And Axel Klein is an independent researcher with specialisms in criminal justice and security issues in Africa. So we're looking forward to them setting us up for this conversation. Then we'll move on to Ewelle Williams and Monalisa Magoche, who are both members of the SSDP Africa Committee and chapter leaders of their respective countries. They're going to give us a little bit of an idea of what they've seen in their respective countries and the kind of youth and student perspective that we want to look at as well. Ewelle Williams is our chapter leader for SSDP Liberia. He's also the vice chair of the SSDP Africa Committee. And then Monalisa Magoche is our chapter leader in SSDP Zimbabwe and the chair of the SSDP Africa Committee. So I'm really looking forward to hearing this entire panel. And Maria and Axel, do you guys want to take it away?
Thanks very much, Róisín. I think I'll just open this up with introducing myself as a member of the Global Drug Policy Observatory and maybe a bit of background. And I'll try to illustrate some of the points we're making with slides that I'm trying to share now. So bear with me as I'm trying to do this. And of course, it wouldn't be coming on. But let me also give you some background to the research itself, because Maria and we were working on a different project in 2015. And as part of that, we were visiting a market in Accra, a drug market in Accra, where crack cocaine, cannabis, heroin was being consumed, was for sale. So we managed to conduct interviews there with a number of people. We learned what many of our observations and previous interviews had already established, is that there was an extraordinary amount of brutalization. Every few weeks, law enforcement would raid this place and arrest people, beat people up, rob them, steal money and drugs of people that were found there. And many were arrested and taken to the police station, where they would then be bailed, as the terminology is. It is really a form of ransom, where family members come and then give money to the police and release the people on lockup. So we were quite concerned about this particular form of brutalization by law enforcement for so-called drug offenders. And a couple of years later, we then learned that Tramadol was under discussion with a view to being scheduled. And we were quite concerned because so many people are using Tramadol in different ways, which we wanted to establish. So when a pharmaceutical company approached the Global Drug Policy Observatory, I got into discussion with them, and this is a manufacturer, Grüntal GRT, manufacturer of Tramadol, and concerned about losing in sales. So we suggested that perhaps they should fund some research we could do on Tramadol use in Africa, and we did that on the condition that there would be no interference in the research, that we would have complete control over the data, and thirdly, that all members of the team would be able to publish and disseminate the information that we were gathering. And then when we move on to the findings, I'll hand over to my colleague, Maria, who was leading the research in Ghana. So Maria, please take it away.
So thank you, Axel. So first of all, I will want us to look at the situation, more focus on why opioid use in West Africa, in terms of the use of Tramadol in West Africa. So what we first of all need to acknowledge is the fact that in West Africa, access to opioid medication is very challenging. So millions of people in Africa still can't access what we call clinical benefits of effective pain management medications and enjoy the freedom of unnecessary suffering. So if you look at Tramadol, it's currently the most effective alternative pain management medication, even though pain alleviation, it's a very central, core pillar of the WHO health policy approach in developing palliative care across the region. Now, amidst this particular crisis, what is actually worrying was the non-medical use of Tramadol, products that have been labeled as Tramadol. And that has actually generated a debate in many governments that have been led by Egypt and calling for it to be internationally controlled. Now, first and foremost, it is important for us to understand the real situation on the ground in terms of West Africa. What many have failed to acknowledge is the fact that the structure of medical care provision across the region is still struggling. It's the fact we are still struggling from decades of neglect and sharp spending cuts on medical care. So existing services tend to focus on preventing infectious diseases and improving the life expectancy of children and mothers. And these are people who are struggling to meet the growing burden of non-communicable diseases. Now, we need to note that sharp increase in the caseload of cancer and HIV are leaving large number of people in need of regular medical attention. And so urgent need for palliative care for helping people with chronic pain is necessary. And most countries are beginning to look at these using different opiate products. But in West Africa, we import just minute amounts of morphine. And so it is not readily available and accessible to majority of those who actually need this. So countries find it difficult to import internationally controlled substances because they need authorization from the INCB before they can be able to kind of find reputable pharmaceutical companies to export this. Now, growing social inequalities means that large section of rural folks, but also of the urban poor, are sorely neglected. And this population rely on informal sectors, especially the rural poor, for their supply of Tramadol. Now, the truth of the matter is that most Africans obtain their medications from markets, chemist shops, wandering traders, because they are those who are readily available to respond to the needs of the people, especially in areas where the structures are non-existent. And so the fact is that people need to treat pain, but currently readily available service for pain medication is not there. So patients will have to rely on these services for their supply. So what that means is that the majority of the so-called Tramadol being used illicitly in Africa does not come from the medical supply chain at all, from our study. So most of these Tramadol that is used is cheap generic pills labeled Tramadol and manufactured in several labs across India, China, which are pouring through West Africa because we have a very weak governed borders, and so it's creating a booming kind of trade for most of these people. So in any international move to restrict medical Tramadol will have a very real impact on this, it will really not have much impact on this illicit market. And so the problem of Tramadol in Africa is less about drug enforcement. It's more about, I would say, medicine fraud. And so medicine fraud is most completely neglected as the issue of discussion in this particular process, because despite the WHO calculations that falsified anti-malaria drugs are causing more deaths between like 72,000 to 267,000 deaths in sub-Saharan Africa, the discrepancies is really in these priorities is really mind-boggling, but we are not focusing the discussion in that regard. So unfortunately, this is where potentially effective actions will need to come in. And it is important to understand the motivation behind this And so from this study, what was really clear is that poverty, unemployment was a driving force in the use of tramadol among young population. And so it is important we begin to look at the fundamental cause of most of these problems, other than looking at de facto criminalization, increasing restrictions, and then at the same time denying people who actually need these pain medications for pain management. On this note, I want to pause and allow my colleague Axel to come in again.
Well, thanks, Maria. That was really comprehensive. So just reiterate, the international scheduling regime that is imposed at the Commission on Narcotics, Drugs in Vienna, and that is policed and supervised by the International Narcotics Control Board, is really designed to, on the first of all, to make medications available to all countries. Secondly, through its controls, to ensure that there's no diversion of these medications into non-medical uses. And hence, the scheduling that is being suggested would not provide any kind of protection against the availability of tramadol in West Africa, because all that tramadol already comes from illicit manufacture and was never designed for medical use. And this was sort of reinforced by the samples that we purchased and that we had tested. And all of these exceeded the normal potency that is used in medical practice. That's normally between 50 to 100 milligrams of tramadol. But what is being sold in the markets is from 225 milligrams upwards. And often it's highly adulterated and there are different substances at work. So this is something which WHO, the World Health Organization, has called substandard, spurious, falsely labeled, falsified, counterfeit medical products, or SSFFC. And this is really quite interesting because when it comes to analgesics like tramadol, there are a lot of falsified products in the market, but also with antibiotics and antimalarials. And there's a far greater lethality, a far higher death toll related to this. And yet there's no internationally coordinated action. And the reason being is that there's no international agency that has a remit for it, and that makes it its business. So we find that when it comes to drug classification, it is not really medical harm or the harm to human welfare that is the primary factor, but the availability of an international treaty and an international bureaucracy, which is very much concerned not with harm, but much more with extending its own bureaucratic remit. And that's why I think we've got to be aware of, and we've got to push back as civil society against these intrusions, but also to direct policymakers towards it. But to summarize, I think I'm going to hand back to Maria to conclude on this.
Yeah, so basically in terms of what we can do, the way forward is that we need to understand that focusing on repressive measures to address the problem is not going to help us address this situation. And so there is need to look at policies that are evidence-based to be able to address the key issues here. So what I will expect the CND to be focusing on is to provide people with legitimate, affordable, and effective alternatives, and that they should be helping to make morphine more widely available, as well as assisting departments in the area of health in making realistic assessment of importation of these needs. Because if we want to go by what is happening now, where morphine is readily not available for people to use, and so it's going to create a very big issue in terms of access and availability. So they should help with protocols and training. They also will need to step up in terms of advocating more about the need to shift away from always looking at punitive law enforcement mechanisms in addressing the problem. Because this way, we will never be able to control the substance, because we've seen what has happened with cannabis and others. We have internationally controlled it, but is it still not available in the market, even in larger quantities than ever? So we need to begin to look at this. So in the end, what we have always done is we end up not thinking that tramadol is kind of like we begin to think that tramadol is a medication that needs to be controlled internationally, but we have forgotten the needs and rights of people who legitimately need it. And so it is important that we place the needs of the users, that is patients, at the forefront of all this discussion in crafting whatever policies. And lastly, I want to say that we need to begin to look at internal mechanisms that we can use internally, and not always looking at using international control as a mechanism to address the problem, because these are administrative lapses and we want people to suffer from these administrative lapses. So we need to begin to look at evidence-based policies that can help us address the problem, other than always looking for a cheap way of addressing every problem that comes before us. On this note, I want to Róisín to take over the moderation.
Thanks so much, Axel and Maria. That it's really interesting because it contrasts so much to the way like the opioid crisis in the US, for the example, like kind of came about. It's a structural difference. It's really important for us to understand the context for our advocacy. I'm going to pass over to Ewelle now, who's going to explain a little bit more about the socio-cultural sides of things and the perspective within Liberia.
Yes, like we're gonna look at the social aspect of opioids in Liberia, like most especially for us here, we use Tramadol, like we have here in a lot of the stores. As I said, we have less restrictions on here in my country, like it's not authorized stuff, like you can, like once you cross 18 years, you can walk to the drugstore, you can use your ID in that. But in my country, it is concentrated with students, like from age range of 16 years, you know, they use it for like, mostly for occasions like events. Like we have something we call music, dance, rap. We have battles, we have Olympics, you know, most of them use it to like to shy away some have some fear, illusion, euphoria, stuff like that, and make their life easier. Others use it for isolation. Not everyone want to be in a place with humans. Not everyone want to have like distraction of someone coming out. So most of them we have to use it and go to school with them. And the risks of it is like when you are caught in school, like you have to be tested, and if tested, and you have to call your parents, and probably you might be immediately expelled as a student. So we have that. We have it as a regulatory policy in most schools, like for Tramadol, codeine. These are restricted medicine. If you are caught, you are expelled, but mostly people use it, and the restriction is mostly within the school arena, like in the public, the society is common. Like I can just walk to the drugstore and buy like 500 milligram and maybe a pack of it. And maybe because I use it because like I want to have some sleep, and I can use it and go to bed. I don't have to like any kind of risks towards it. But the problem is, but we have like low education on it here in Liberia. We are not educated about it here. Like most people don't know how to use it, and the risk factor, they're not aware of it. So like it's something more social game here. Like we use it to like feel ourselves, make ourselves feel happy, and to just rock around. It's an issue globally too. In Liberia, it's also not an issue, but it's not even a prescribed medicine that you can take in a hospital like Tramadol. No, the prescribed is diazepam. That is the prescribed one that you can take for pain relief and stuff like that. So for us, it is occasionally authorized. Like if otherwise, if you are caught with it, probably maybe in a school vicinity or in an environment like maybe you are selling street, something like that. If you are hold by authority, you may be penalized and you may pay the fine. But other than that, if you are just using it on the streets and in your house and in your schools, probably you might call in for interrogation, stuff like that. And I also did a research on campus with students who use like mostly the codeine. Like we also use it like with zip. We call like, it's usually called zip. Like some people like zip like 2-3 bottles a day. Some zip every day they zip like 1 bottle a day. So it's something like have adapted to the usual health style. Like if they go out of it, they feel unusual and stuff like that. So like for me, I think it's something that in my country, it's cool. And we just look at that for Tramadol, like we are not seeing it to be under international control. We all know that codeine is under international control as well. So like we also like push for harm reduction strategies that help us to like the user here in Liberia, like the young people to have education mind about it. Like people who inject it, people who use it and stuff like that to have an education of it. And also we push for drug education in school, especially for opioid users, like for those who use like Tramadol, stuff like that. So like, this is where we look at it from a social perspective, not like a harm here. It's not like a restriction here. It's not like a warrior in my side of my country. It's not like a warrior in this region. It's something like super cool, like a paracetamol, like you can just prescribe it and take it. And even if your parents know that you're taking Tramadol improperly, and they got a scale like, oh, you want to kill yourself and stuff like that, but it's something usual here. Like in most homes, most people are aware of Tramadol, and some say it makes them crazy. Some people say that discriminatory measure, it make people crazy, it make people steal, it make people drowsy, stuff like that. But all of those things, people still use it, and it's super cool here. So from my side, it's super cool here. Like in Liberia, it's not a restriction here. It's not a war also here. Like Tramadol, codeine, it's something like, because codeine is a cough syrup here. We usually use it for cough syrup. Like if you're coughing, you could use it, but most people like overdose. Like you have to drink like 3 to 4 bottles before you can have that content of being drowsy and able to like have that recreational move and stuff like that. So like it's very important, as Maria said, like for the policy level, it's very important that we look at our national work is not the international work as well, because like codeine is on international control, but people still abuse it all over like West Africa stuff. So I'm going to take a bit. I'm going to start here and turn the page to my colleague Monalisa Magoche, where she's going to explain about her experience of opioid crisis in Southern Africa.
I'm going to present on opioid crisis in Southern Africa, mainly focusing in my country, Zimbabwe. So the opioid crisis in Zimbabwe is mainly emanated from the shortage of opioid supply from pharmaceuticals. In Zimbabwe, for example, the supply of opioids in pharmacies has been banned. Like in Zimbabwe, here we have the most popular opioid that we have here in Zimbabwe is called Bronglia, which is a codeine syrup. So this Bronglia was banned from being supplied in the pharmaceuticals. So this has led to severe pains to patients. For example, if someone is having a severe cough or a pain, they can get the Bronglia from the pharmaceuticals. Then what? To cater for these pains, some patients have opted to buy opioids from the black market. So in Zimbabwe, opioids are channeled through improper channels like the black market. They are mainly imported from South Africa, mostly through the Bedbridge border post. And also Zimbabwe acts as a transit of opioids transportation from South Africa to Botswana. So we have seen many cases of opioids use in Zimbabwe. So these illicit importation routes and informal distribution channels has led to the supply of substandard opioids, which then resulted in the opioid crisis. Patients with severe pains, for example, buy opioids from the informal markets, leading to overdoses and addictions, and improper prescriptions or use, which leads to addiction. So also in Zimbabwe, like if you follow economies well, in Zimbabwe currently there is massive unemployment and the economy is currently poor. So you know most of the youth, particularly from the age of 18 to 40, use these opioids to curb away the stresses and the depressions associated with unemployment. In Zimbabwe also, opioids are cheap from the black market. A bottle of Bronglia costs about $3 US. Tramadol is limited in supply, but it's normally costs around $1 US. Another form of opioids which is also used here is called gutter water, which is a mixture of codeine, tramadol, cannabis, water, and juice. So it's another commonly used opioid this side. So, you know, the supply of opioids from the black market and not from the pharmaceuticals has been very problematic to the youths who want to curb such stresses in the context of unemployment, poor economies, and a bleak future. Recently, I was talking to this 31-year-old guy who was like, I consume gutter water. Why? Because I haven't found work yet, and I'm still staying with my parents, which is so embarrassing. So to curb the stresses, I make sure that I drink gutter water just to make sure that I don't feel embarrassed. So here in Zimbabwe, unemployment unemployment has been the major factor which is causing opioid consumption in Zimbabwe. And also in the CBD of Harare, when you walk early in the morning, you see bottles of brown bronco bottles, broccoli, I mean, in the streets and gutters. They are consumed by the street kids mainly, a sign of the addiction crisis the nation is failing to handle. We also have hotspots areas like here in Zimbabwe, we have Zimbabwe, where people exchange those opioids. So in Zimbabwe, there is an opioid crisis, and it's mainly prevalent from the age of 18 to 40, according to the research which was recently done by the Ministry of Health in Zimbabwe. So we have lost young people, many deaths, mental health issues and stuff because of the opioid crisis. Also, at my home back there in the rural areas, there was a death recently of a 19-year-old boy who overdosed 5 bottles of undiluted Bronclia. And also there was a policeman who was abusing Bronclia again, who ended up eating from the bins as a result of mental disturbances. So there is a disturbing opioid crisis here in Zimbabwe. So also taking a look at South Africa, in South Africa, they normally consume what you call nyaope, which is a heroin, which is a mixture of cheap heroin and cannabis. So I think basically that's the situation here in Zimbabwe. Opioids are normally channeled through improper channels. There is improper supply chain management here in Zimbabwe. And the black market is now supplying substandard debt of young recommendations that I have for our economy and the government. I think that from my own perspective, the government should make sure that it doesn't ban the supply of opioids from pharmaceuticals, because it has resulted in the supply of falsified and substandard opioids in the streets. I suggest that the government of Zimbabwe should just allow pharmaceuticals to supply the opioids. And also, they should eliminate corruption at the border posts in order to discourage the importation of vast volumes of substandard medicines. Let them just allow the pharmaceuticals to supply the opioids. And I think once the government deals with that, the demand for opioids will subside. Also, I also discourage, from my own perspective, the ban by the government of Zimbabwe of the supply of the opioid substitution therapy from the United States federal government. Like, for example, right now, we are in the midst of a coronavirus pandemic. And you know, many young addicts who are addicted to those opioids are suffering from withdrawal symptoms because they are home and they don't have access to opioids or to the substitution therapies. Why then can we allow the health facilities of Zimbabwe to supply those opioid substitutions to cater for the withdrawal symptoms, like now in this coronavirus pandemic? Yesterday, I was watching a certain program from a South African television, whereby young people in South Africa were accessing opioid substitution therapies from local health facilities because they have seen that the policies which are being conducted in other countries have failed. Let's just have opioid substitution therapies to make sure that people don't suffer from the withdrawal symptoms. Also, not forgetting our role as the young people. We need to continuously sensitize and educate young people.
We're just coming to the end of time here. I'm so sorry to interrupt you.
Thank you.
But maybe we can follow up on some of the extra things you have to say in the Q&A or later on. But I want to say thank you so much to all of our speakers. You guys have been amazing. This has been like a landmark moment for SSDP because we haven't been able to get our members from Africa to the conference for a long time now due to visa issues, and having you guys here and speaking is really, really amazing, and I really appreciate it. And as well, thank you to Maria and Axel. You have given us a fantastic opportunity to learn so much more and spread this a lot further. So thank you so much.